Welcome back everyone, Dr. Naveen here from UPSC MEDICO. So in this video we'll be discussing 2024 MCQs from orthopedics topic from the subject general surgery of UPSC CMS exam. So we have select topics, select syllabus for UPSC combined medical service examinations, and in 2024 the major change was there was increased weightage. Usually they used to ask one or two questions from orthopedics, but they have asked four questions from orthopedics this time. Similarly, there is an increased weightage even for dermatology and also anesthesia. Okay, so instead of asking one or two questions, they went up to 6 questions in dermatology. That means for the upcoming 2025, it is important that we focus on these mini subjects because the weightage, overall weightage is increasing. Okay, so we will discuss these 4 questions in this particular video. Right, this is your take home. And the second thing is, when I say orthopedics, okay, you don't have to go back and open orthopedic textbooks, right, that we usually read in MBBS. So they're not asking questions from orthopedics part of the textbook. There is an elective orthopedics which is mentioned in the Bailey and Love itself. So the questions will come from the elective orthopedics part of Bailey and Love of general surgery, not the regular. We have different books for orthopedics which we usually follow, right? Maheshwari is there, Campbell's is there. So they're not asking questions from there. So if you're preparing for CMS, don't open and read from standard orthopedic textbooks. The elective orthopedics part which is mentioned in the book is more than enough because questions are directly being copy pasted there. The third important thing that I wanted to tell you is that yes, elective orthopedics is different. The traumatic orthopedics, the trauma related, road traffic accident related, are a separate entity. So there is a separate heading for that, that is traumatology. So in our UPSC CMS course, we have a separate lesson called traumatology, wherein any road traffic accident related orthopedic fractures etc. will be discussed there if they are relevant. Okay, this is purely elective orthopedics which is being asked in the exam. We have 4 questions in 2024. Now the question number 1, as you can see here on this side of the page, we have question from UMN versus LMN lesions. Now if you are a serious aspirant of UPSC CMS, you know this UMN LMN lesion is very important even in the neurology part of general medicine. So there are 3 to 4 questions in the past which were asked in the general medicine from neurology. The same thing, the key differences between UMN and LMN. The question now popped up in the orthopedics part because in the spinal cord, injuries to the spinal cord, this topic is specifically given in the orthopedics part of the general surgery. Right? So now let's look at the question of 2024. Upper motor neuron lesions are characterized by, it's a multiple completion type question, there are multiple options. Now, increased tone spasticity, hyperreflexia, absent plantar response, and motor weakness. We'll come back to that. First, let's try to understand what is an upper motor neuron lesion versus what is a lower motor neuron lesion. So, upper motor neuron lesion parts are brain and the spinal cord. If any lesion, for example, if there is a stroke or if there is a spinal cord damage or spinal cord injury, okay, in these kind of examples like stroke and spinal cord injury, the brain gets damaged or spinal cord gets damaged, then you will see features related to UMN. Whereas the lower motor neuron will start from anterior horn cells within the spinal cord, and from there you have a spinal nerve, you have a neuromuscular junction, you have a muscle plate, and you have a muscle. So anything which affects the anterior horn cells are affected. In classic example is, I'll also writing the examples, that is poliomyelitis, or anything which affects the spinal nerve, neuropathies. Okay, the classical example are any neuropathy, it is a LMN lesion. Similarly, anything which affects neuromuscular junction or anything which affects muscle end plate or muscle or myopathies. So all these classical things, they lead to LMN type of lesions. So now you know what is an upper motor neuron part and a lower motor neuron part, and what is the classical disease examples of this. Now let's try to differentiate these. Okay, we'll take up a feature. Okay, we'll take up a feature and we'll try to differentiate LMN. We'll take UMN first in this column and we'll try to differentiate LMN. Right? So the first feature I want to tell you here is uh, we need mnemonics are some dictums to understand this. Okay, I'm usually not a fan of mnemonics because if you understand the concept, you don't have to by heart or mug up thousands of mnemonics in medicine. But UMN is all about more. LMN is all about less. Okay, all about less. UMN is all about more. Let's see how they are, how each of these are different. First, we'll take up tone. When you look at the tone, as I said, more, that means the muscles are hypertonic here, they are hypotonic here. Simple. The tone is hypertonic and hypotonic. This is the first key difference that you need to understand with regards to tone. Okay. Next thing is about reflexes, that is deep tendon reflexes or DTRs. Okay, or abdominal reflexes, whatever it is. Now, as they are more, I can say it is hyperreflexic here, and this is hyporeflexic, or reflexes may be absent. Hyporeflexic or reflexes may be absent. This is the second thing that you need to understand. So more in the sense, more tone, and reflexes are exaggerated. Okay, a hyperreflexes means exaggerated. Simple thing. So now the more part is this. Now coming back to increased tone also is related to, if the tone is increased heavily, then it leads to clonus. Okay, so the clonus is present in case of UMN, the clonus is absent in case of LMN, and based on this clonus topic, 2 MCQs has come in the previous year questions of UPSC CMS in general medicine part. Okay, tone and clonus are related, right? So tone is present in UMN and absent in LMN. Tone is present in UMN and absent in MN. Now the tone reflexes part is done. Now coming back to one important element that you need to remember here is the we can either call it as Babinski's sign, present or absent, or we can also call it as a plantar response. Plantar response is actually extensor response. That means it is up, the toes goes up, right? Here it is flexor response, or it goes down. So different terminology they use, but the end point is same. Babinski's sign is present in UMN, plantar response is extensor, or toes goes up in case of UMN lesion, whereas it is flexor response, downward response, or it is negative. The Babinski's sign is negative with regards to LMN thing, right? So these are the few are the major important differentiating factors which we see. Next is muscle. Usually the muscle wasting or muscles wasting is usually not seen in case of UMN lesion immediately, but LMN lesion is characterized by muscle wasting. If at all there is a muscle atrophy, if at all by any chance if there is a muscle atrophy, it is actually because of disuse which develops later, but muscle atrophy develops very soon because of denervation. Okay, innervation. I think I had to put E here. So de-innervation atrophy is classic of LMN lesion. Disuse atrophy is classic of no. But muscle wasting is usually not seen in UMN, but it is classical picture of LMN. Classical picture of LMN. Now, one more point I wanted to add with regard to tone, or we'll take it as separately. Okay, the type you see is okay. Here as the tone is hypertonic, so this kind of tone increase we call it as spastic tone. Okay, this is spastic tone. So it is spasticity which is present because these are flabby. This is flaccid. Okay, it is spastic tone, flaccid tone, hypertonic, hypotonic, clonus present, clonus absent. Clonus present and clonus absent. Done. Now, with regards to muscle, there is one more important differentiating feature. Muscle spasms are present. Okay, muscle spasms are present, but here muscle weakness is present, and one differentiating feature that should be highlighted here is fasciculations. Fasciculations are present. So the things which are in red, spastic, flaccid, and also very importantly about the Babinski sign, there are a lot of questions. Now coming back to MCQ, UMN lesions are characterized by simple, yes, increased tone spasticity, yes, hyperreflexia, yes, absent plantar response, no, it is actually present. Motor weakness, yes, motor weakness is also present in cases of UMN lesion, because motor nerves they get affected, right? If you see hemiplegia, okay, hemiplegia, you will see motor weakness. Motor weakness is part of both UMN and LMN lesion. So 1, 2 and 4 are correct. So the correct option is option 2, 1, 2 and 4. So this table is very important for your exam. There are a lot of MCQs, 4 to 5 MCQs in the last 5 years, just differentiating UMN and LMN lesion. And if you are a final MBBS student, you do understand the importance of this topic, right? So the next question in orthopedics is a swelling related test. Okay, there is a 20-year-old girl. Let's write down the clinical scenario here. So the gender is female here. Gender is female here. Age is 20 years. Okay. Now complaints of swelling. Whenever we look at swelling, the points you look at is location. So where is swelling present? Swelling is present on the wrist. Swelling is present on the wrist. Next, what is the onset part of the swelling? Onset is insidious, slowly progressive. Slowly progressive. It is not acute. Acute swelling is more or less infectious, but it is insidious, slowly progressive swelling. And it is increasing. It is increasing. And the aggravating factors here are, it is becoming more prominent. It is becoming more prominent on plantar flexion of wrist. Plantar flexion of wrist. So whenever wrist is undergoing plantar flexion, the lesion is increasing. And what is the size of the swelling that you see here? It is 2 centimeters to 1 centimeters in size. And what is the characteristic of a swelling? Very important. Characteristics of a swelling. It is cystic in nature. Okay, and it is non-tender. It is non-tender. Right? So any cyst is cystic. So sebaceous cyst is also cystic. Dermoid cyst is also cystic. Epidermoid cyst is also cystic. But the ganglion cystic has a characteristic site that it is arises on the wrist. Okay, it is arises on the location wrist. And also one clinical clue here is it becomes more prominent on plantar flexion of the wrist. That means whenever you see our ganglion cyst, I'm talking about a ganglion cyst. So the diagnosis is retrospective, and there are a lot of characteristic features that you need to know here. When I say a ganglion cyst is commonly found on dorsum of wrist. Okay, it is commonly found on dorsum of wrist. It is a smooth, well defined fluctuant swelling. Okay, it fluctuates. So it is a fluctuant swelling, and it becomes prominent on wrist flexion. So whenever wrist is flexed, as you can see in this image what I'm showing here, when the wrist is flexed, it becomes prominent because the underlying joint connection is there. Whenever it is flexed, it opens up and the swelling pops up. So it is linked to the underlying joint capsule or a tendon sheath. That's why it becomes prominent whenever there is a flexion. Okay, and you know this ganglion cyst is commonest cause of hand swelling. Okay, that's why the question has come up. Whichever is common, they will ask questions, right? It is commonest cause of swelling in hand. One important feature, commonest cause of swelling in hand is ganglion cyst, and it is trans-illuminant. That is, trans-illumination is positive in these cases, and presentation part, they rarely cause discomfort. They rarely cause discomfort, but there are locations on the wrist where they are present. Usually they are present on the dorsum, as you can see, or volar surface of wrist. When they are present here, they rarely cause discomfort. If yes, there will be a little bit of discomfort here. But sometimes they are even present on the dorsum of the digital interphalangeal joints. So they can also be present here. Okay, distal interphalangeal joints. If they are present here, okay, if they are present on this location, we call it as a digital mucus cyst. So this is what you see is digital mucus cyst. So they have features of nail changes because they are very close in proximity to the nails, and they also complain of discharge. So the patient presents with discharge if the location is on the DIP joint, that is dorsum of the DIP joint. If it is within the tendon sheath at the base of the fingers, okay, within the tendon sheath, if you see a tendon sheath here at the base of the finger, if it is present within this, we call this as a seed ganglion. The third location, the third common location for the ganglion cyst is seed ganglion. The problem if they are located inside is that they are painful. They are very painful. They are very painful and they are gripping in nature. Painful and gripping seed ganglions. Nail changes and discharges are seen with digital mucus cyst, which is present on the dorsum of the DAP joint. Or the commonest location is dorsal or volar aspects of the wrist, which usually causes discomfort. Unless there is symptomatic, we usually do not treat them. But if you want to treat these condition, the treatment is aspiration. But let me tell you, high chances of recurrence is there. So you should tell the patient even after aspiration, high chances of recurrence are present with regards to this ganglion cyst. If they are recurrent, the next option is surgical excision. That's it. These are the few points that you need to know about ganglion cyst. Now coming back to question, 20-year-old girl with complaints of progressively increasing swelling on dorsum of the left wrist, cystic, non-tender, prominent and plantar flexion of the wrist, swelling size is 2 cm. All are pointing to our diagnosis, that is ganglion cyst. Now the next question is, a 52-year-old, so the gender is female. What is the complaint? The complaint is pain in right shoulder. Okay, pain in right shoulder, and also limitation of movements. That means she is unable to do overhead abduction of the affected joint. As you can see, it is difficult. So limitation of movements, pain which is unilateral, She had been known or history of diabetes mellitus is present. She is under treatment. So all these three features, okay, diabetic, pain in the right shoulder, limitation of movements. So the probable diagnosis or the probable differential diagnosis can be osteoarthritis. Osteoarthritis can cause this kind of stuff, or it can be rotator cuff tear, or it can be frozen shoulder. Now how to work out on differential diagnosis, I'll tell you. Now the osteoarthritis is actually insidious, that is slowly progressive, so it can be a potential diagnosis. Whereas rotator cuff tear, it develops suddenly, or acute onset severe pain. So because here in this case the female is complaining of increasing pain, slow, and that means it started at grade 0, grade 1, and the pain is increasing, okay, slowly. So it is more or less insidious in onset, right? So you can definitely rule out rotator cuff tear here. And one important clue here is that diabetes mellitus. So there is link between diabetes mellitus versus frozen shoulder, and frozen shoulder is seen in age group of 40 to 60 year, more common in females, associated with diabetes mellitus or cardiac disease or thyroid disease, and patient presents with pain which is severe and also associated with the limitation of movement which is characteristic. So we call it as a global limitation of movements. So all these points are mentioned in the clinical scenario, that gives us a final diagnosis of frozen shoulder. I'm not going for bacterial arthritis because it is more or less swelling will be present, redness will be present, and arthritis will have systemic symptoms like fever and all, which are not mentioned here, which can also be a potential differential diagnosis. So my end diagnosis in this condition is frozen shoulder. Frozen shoulder is a idiopathic, painful, stiff condition. Mostly females in the age group of 50 are affected. Diabetes, heart, and thyroid disease are prominently present. Right? That's it. Now the next question is from arthritis part. Okay, let me write the clinical scenario here. You have a 40-year-old female again, and what is the complaint? Complaint is progressive deformities of the hand and fingers. So hand deformities is a important topic in orthopedics part, where lot of times questions will be repeated not only in CMS exam, even INA, CET, NEET, PG, USMLE also. Lot of times questions will come. So the hand deformities, there are Haberden's notes which are seen in osteoarthritis, which has been asked, but there are some deformities that you need to know with regards to rheumatoid arthritis, where a lot of questions are coming up. Okay, so the classical picture of rheumatoid arthritis is given here, that there is progressive deformities of hands and fingers. There is stiffness which is present in hands and improves as the day progresses. So this is a classical presentation of morning stiffness. So there is morning stiffness. There is a female of 40-year-old who has hand deformities. All these are pointing to our very own diagnosis, that is rheumatoid arthritis. So the other feature which is supporting the diagnosis is symmetrical involvement. Okay, symmetrical, because osteoarthritis is asymmetrical. Okay, osteoarthritis asymmetrical. Okay, and the clue here is flexion deformity and ulnar deviation of the MCP joints. That means I am talking about a Z deformity, and also I am talking about ulnar deviation, which are classical hand deformities of the rheumatoid arthritis. So my most likely diagnosis in this scenario is rheumatoid arthritis. Okay, so rheumatoid arthritis presents with classic symptoms like morning stiffness. Okay, and rheumatoid arthritis also has features like symmetrical arthritis. It also has features like hand deformities. All these are classical things. So what are these hand deformities? So the discussion is incomplete if you do not discuss this hand deformities. The one classical hand deformities is boutonniere deformity. You might have heard about it before, but very important for MCQ based exams. That is, what is this boutonniere deformity? There will be hyperextension of, I'll show you the image, first focus on the wording. Hyperextension of metacarpophalangeal joint, MCP joint. There is flexion of proximal interphalangeal joint, and there is again hyperextension of distal interphalangeal joint. Now let's look at the image of the boutonniere joint. What is this? This is, you see here, there is hyperextension of MCP joint. There is flexion of proximal interphalangeal joint. There is again hyperextension of distal interphalangeal joint. So this is distal interphalangeal, this is proximal interphalangeal, and this is MCP. So there is hyperextension, flexion, and again hyperextension. So this is boutonniere deformity, which is classically seen in rheumatoid arthritis. So we also have another deformity, that is swan neck deformity. So in swan neck deformity, yes, there will be hyperextension of MCP, but what is more important is, here you see, instead of flexion of PIP, you have hyperextension or extension of PIPJ, and there will be flexion of DIPJ. So that means the reverse is happening here. There is hyperextension at proximal interphalangeal, extension at distal interphalangeal, extension, all these, hyperextension at PIP, flexion at DIP, this giving a swan neck kind of deformity. Swan neck, boutonniere are the two classical deformities. Apart from that, there is a Z deformity of the thumb. You can see this is because of what is happening here. here there is a hyperextension of the interphalangeal joint and flexion of the MCP joint. So flexion of MCPJ and hyperextension of IP, that means interphalangeal. Only one phalanx is there. You cannot call proximal or distal in case of thumb. That's why that is Z-shaped thumb. The fourth important feature or hand deformity you see is a ulnar drift. Ulnar drift. So in the ulnar drift, as you can see here, there is a ulnar deviation of the fingers. All the if this is radius and if this is ulna, what you see, all the fingers are deforming or moving towards ulna, that is drift towards ulna, or ulnar deformity or ulnar drift is classical of rheumatoid arthritis. So all these are the possible hand deformities, and this ulnar drift occurs because of subluxation of metacarpophalangeal joint, and Z deformity of thumb. Z deformity of thumb, as I said, is because of flexion of MCPJ and hyperextension of interphalangeal joints. That's it. These are the hand deformities that are seen in rheumatoid arthritis, and this will conclude our discussion of 2024 orthopedic related UPSC CMS questions.